I'm Lauren Henke, and I'm here today with my co host, Dr. Stephen Chun, for another episode of the NRG Oncology Podcast. Today, we are thrilled to be joined by the 2025-2026 American Medical Association, or AMA, President, Dr. Bobby Mukkamala. Dr. Mukkamala is an otolaryngologist who has been practicing in Flint, Michigan. Just a few of his many accomplishments include establishing major public health programs to mitigate the impact of lead in drinking water in Flint, establishing endowed health scholarships at the University of Michigan, and serving on the AMA Council on Science and Public Health. These efforts have been recognized through the AMA Foundation's Excellence in Medicine Leadership Award.
As an Asian American myself, I couldn't help but notice that Dr. Mukkamala is a trailblazer, being the first physician of South Asian Indian descent elected as president of the American Medical Association. In fact, I can only recall perhaps one other Asian American Medical Association president, Dr. Robert Waugh, who served about a decade ago in 2014. Dr. Mukkamala, welcome to the NRG Oncology Podcast. I know there's been a lot put out there on your own cancer story recently. Before we get into everything you do with the AMA, I wonder if you could start off telling us your story in your own words.
Thank you. It's great to be here, guys, and I appreciate having a wonderful conversation with you. My diagnosis began just at the end of last year. In November of 2024. I was giving a speech at the American Medical Association. This was a group that has heard me speak for years, right? More than a decade, they've known me. And I'm at the microphone giving an update, pretty standard stuff, like a zero stress situation. And all of a sudden, the words just weren't coming out right. And I was kind of lost in what I was trying to say. And it wasn't the first time that that happened. And in hindsight, over the course of the year prior to that, just different moments where in the middle of saying something, I would lose track. I just thought, you know what? I'm in my 50s now. This is just me getting older. But when I was in front of the AMA group that had heard me speak so much, they didn't think that at all. In fact, one of them stood up and said, "We don't understand you." And I kind of tried to make the excuse that I'd lost where I was trying to speak. And anyway, I finished that presentation. I go to the next room and give a flawless presentation, and they all clapped as soon as I walked out of that room. Man, everybody was around. My wife was there, the chair of the board was there, and they all got an alert from the people in the first audience that we think Bobby had a stroke. And so I was told, when your wife tells you something, you just do it in this situation. So down in Orlando, we go to an urgent care just because it was convenient. And they did routine stuff, but everything was perfect. The blood pressure, all the vitals were fine, EKG was fine. And that's when we figured, okay, if something happened, maybe it was a TIA, right? It wasn't anything major. When I got back to the AMA and told everybody what the result was, they said, okay, when you get back home after the meeting's over, just get worked up for a TIA. So this was like on a Saturday. Tuesday, the meeting ended, and I go home. And that evening, went to a neurosurgeon's office where he has an MRI scanner, and I get my MRI scan done. And when I start looking at it on the computer screen, then I start to see this spot on my left temporal lobe, medial temporal lobe. And at first I thought it was something on the monitor, like some sort of stain. So I started to wipe it, and that didn't work. And this thing is getting bigger and bigger and bigger. So then at the end, I'm looking at an 8 centimeter medial temporal lobe tumor. And that's when I WhatsApp called my dad, who's a retired radiologist. And first he thought I was just asking about a patient. But then when he realized my name was on that report, that all of a sudden things got serious. That's sort of how we got it diagnosed. And to make the rest of the story shorter, within a week, I had half a dozen consultations with amazing neurosurgeons. And 3 weeks later, ended up getting my awake craniotomy, 12-hour operation at the Mayo Clinic, and they got 90% of it out. Turned out to be a grade 2 astrocytoma. And when my family Googled that, they kind of freaked out because if you Google it, it says basically an average life expectancy of 10 years. But at that point, I was happy that it wasn't a grade 4. And the amazing thing, and there's a lot more to talk about, there's this new medicine, this IDH inhibitor that might eliminate the need for radiation and chemo, that I might have a much longer than 10-year survival. So it was just an amazing intersection with the healthcare system that I, as the AMA president, would have a very different perspective on. But now that I'm a patient, man, my brain is smaller, but man, has my intelligence about how this system works gotten better.
I just want to say thank you for sharing this amazing story. Most of our guests on the podcast tend to be physicians, and while we tend to have a fairly physician-centric worldview, but Stephen and I have felt strongly that we need to hear the voices of patients who we ultimately serve. Dr. Mukkamala, you have actually not been the first AMA president diagnosed with a serious cancer at the outset of your presidency. Almost 20 years ago, the 2007 AMA president, Dr. Ronald Davis, was diagnosed with pancreatic cancer, and in keeping with the gravity of that diagnosis, passed away later in 2008. His presidency was, of course, very greatly impacted and colored by his pancreatic cancer diagnosis. How has your own diagnosis impacted your work and your vision with the AMA?
It's had a massive impact. Naturally, in that first day or so, it was panic, it was misery. My whole family's freaking out. And I tend to be, for better or worse, a little more Spock like, Dr. Spock, versus Captain, what's his name again?
Captain
Captain
Kirk.
Clerk. Yeah, Captain Kirk. Yeah. So I tend to be more logical, like, okay, what are we going to do next? And then as I started to navigate the system and have these consultations, I live in Flint, Michigan. Immediately, I realized that what I have access to, telemedicine consultations with not just general neurosurgeons, but neurosurgeons who work every day on gliomas. That sort of specificity, there is no way that anybody in my neighborhood would have that kind of access. And I know that, on the overall spectrum of access, I'm at the top. But even those of us that have amazing healthcare coverage, that have access to this stuff, we're not going to get consultations done within a week and an MRI scan done within hours. And so I look at that gap, and it's such motivation in the impact it has on me for what I'm going to do during my presidency. And AMA policy is pretty broad. Everything that needs improvement in healthcare is in our policy manual, and it's in the work that we do. This is where my adrenaline gets going versus memorizing a speech and coming up with listing these 5 things, but it's not necessarily energy that goes into that part of the speech. When the part of the speech has to do with access to care, to the stuff that I got done for me that my neighbors can't get done, that's what gets my adrenaline going. And so that's how this diagnosis has impacted the work that I do. And I think that it's had a ripple effect throughout the American Medical Association. I don't want anyone to experience a pancreatic cancer like Dr. Davis. I don't want anyone to experience a brain tumor like me. But knowing somebody that's otherwise exactly like you, right? Same profession, same route of studies and residencies to get to this position. When one of our colleagues, our peers, goes through something like this, there's a positive ripple effect. It makes us all aware, a little bit closer of what the health system is like and what needs to be better about it.
Since you bring this up, I think that one area we can certainly do better in terms of clinical trials is increasing access to medically underserved areas. As we mentioned earlier on this podcast, you've had enormous success using out of the box ideas to improve access to medical care there in Flint. I'm from Hawaii, where we also see huge challenges to implement clinical trials, especially in some of the more remote islands of the Pacific, which comes with a substantial price tag. I think everyone listening to this podcast would agree that we should be trying to make clinical trials available to all people. What words of advice could you give our NRG oncology stakeholders on improving access to our trials in, let's say, places like Flint or anywhere else that might need access to these life-saving and practice-advancing trials?
I think that's a wonderful goal and a wonderful investment of ideas. How do we achieve that goal? Like that sort of thought process. This has also been a priority of the American Medical Association. When the AMA sees something that needs improvement in healthcare, but doesn't tend to see a solution out there or a company that's interested in doing something, like pursuing exactly this clinical trial research that's more in the community as opposed to the ivory tower. When that doesn't exist, but it's something that the AMA finds important, we create it on our own. And we do that through an entity that we've started, and it's based in California, called Health 2047. And in that, one of the things that we've started is called Site Bridge Research. And that's a spin out of Health 2047. And basically, the goal of that is to make this research something that serves these underserved populations that would never otherwise have access to it. And there's so many benefits to that. The key benefit is just the population that's involved in these clinical trials, I think is more reflective of the population in this country. I'm a University of Michigan alum. That's where I spent undergrad in medical school. And when they're doing research and somebody from my community in Flint, Michigan might be a good candidate, that means my patient has to go down to Ann Arbor to participate in this stuff. That's a problem, right? But if they could come to my office and participate in that kind of clinical trial where it's more convenient and more indicative of the general population, that's a fantastic direction to go. And so I'm glad you bring that up because I think we can do better by involving physicians in this process. In fact, I was in DC and I heard Dr. McCary talk about exactly this kind of issue, like creating a more agile, faster way to improve the health of our country by having research go faster. And I think this is a critical aspect of that.
As I'm sure you're aware, many of the treatments that are offered for patients with cancer and treatments for things like gliomas have been developed and are championed through the National Cancer Institute sponsored cooperative groups like NRG Oncology. With cancer now as the leading cause of death in the United States, I suspect that the AMA will continue to be a major advocate for federal cancer research funding, especially at a time when it seems like there's an increasing skepticism about the clinical science that we do. Can you speak to the public out there on your view of NCI-sponsored clinical trials and the work of the AMA in this arena?
I couldn't agree with you more. The AMA couldn't agree with you more. This is how we evolve as a country. This is how we evolve as a planet, is moving in the direction where we don't put leeches on the skin of somebody that needs modern healthcare, right? In my own experience, we don't cut out ulcers when we realize that this is something that needs an antibiotic for H. pylori, right? This is the evolution of healthcare. And that's the kind of thing that happens at the National Cancer Institute. I mean, it's critical. The skepticism that arises about this clinical science that we are spending hours and hours and years and decades when there's skepticism about the result of that, that is a problem. And what I realized is that this brilliance that comes up with the consequences of this research, if that brilliance is put out as a white paper without the charisma that oftentimes finds its way to social media, it's relatively useless when faced with the skepticism about that very science, right? Award-winning science. How do we solve that problem? How do we help people with the science we've discovered? How do we help people by explaining to them, you don't need that thing cut out of your stomach, you need this antibiotic? Unfortunately or fortunately, I think some of that has to do with charisma. If we create a 90-second social media experience that brings our patients in, because you know how things are when somebody's trying to explain something. The speeches that I give, right? When I was in Washington, D.C. yesterday, the first 10 seconds is about what does that guy look like? How's he speaking? What are his facial expressions? And then after 10 seconds, they're like, okay, you know, the science makes sense too. I mean, that's unfortunate, but that's the reality. And so I think that's what we can do better to get people to understand and have faith in the science and defeat the skepticism that occurs, because that's an uphill battle.
These are such great points and actually play into some of the reasons why we even created this podcast, recognizing that we as physicians need to do a better job at communicating the science. We need to do a better job of communicating in plain terms in a media that people can understand why we're recommending the things that we do.
Yeah. So, you know, we have a problem with gun violence in this country. And when there's white papers that come out that basically talk about why this is such a problem and this is why we need to solve it, it's a white paper that gets maybe 2,000 hits. When I heard about a school that was a victim of gun violence, I decided to see how easy is it to buy these semi-automatic weapons. And so I went out and I bought an AR-15 just to see if it was easy or not. And sure enough, in 14 minutes, having never touched a gun before in my life, I now owned an AR-15 and 90 bullets, 14 minutes. And I put it on social media. I said, we got a problem. That post, it wasn't a white paper, it was anything but a white paper, got 2 million hits. on social media. And that's the difference between a white paper and something that resonates with people on social media. And that's why I think we need to move in that direction.
That is an incredible example, and part of the reason why we were motivated to create this NRG Oncology podcast, just putting in writing the concepts that we're trying to convey, we essentially realized probably wasn't going to get us as much mileage as directly speaking to people. Moving on to something slightly different, I wanted to change the conversation a little. We obviously, as a cooperative group, come to groups like the AMA or ASCO or many other advocacy groups asking for things all the time. But there's the old saying that to whom much is given, much is expected. I think it might even have biblical origins. I believe John F. Kennedy might have used it in a slightly different way, this saying something like, think not what your country can do for you, but what you can do for your country. So, on one hand, it's a challenging time for us to get funding in cancer research. But on the other hand, I think people might forget that the United States is the most generous country in the world by far when it comes to funding cancer research. So, again, to whom much is given, much is expected. You being a patient with cancer, but also the AMA president, tax-paying American, what are your expectations of a group like NRG Oncology? And what are the areas that we can perhaps do better in collaboration with groups like the AMA?
I feel like it's your willingness to do me a favor beyond the science of healthcare. And to me, that's enough. My gut reaction is, man, you guys have done so much, right? The fact that I potentially might survive indefinitely. Again, if you do a web search, it says 10 years. It's not unreasonable at all to think that it might be 20 or more. This might not even affect my mortality. And then the research that goes into it and the IDH inhibitor that I'm on now and avoiding radiation and chemo. So all I can say is thank you. Now, thank you being said, what else can you do? In groups like yours and groups like mine as an otolaryngologist, I think that looking for unity within the physician population will help us improve this country because what I see at the American Medical Association, you put 10 physicians together, you're going to get at least two different opinions on what we should do, maybe even five, probably not 10, but the point is that there's a difference of opinion. When 1,000 doctors get together in the House of Delegates at the American Medical Association, there's going to be difference of opinion. But I use the metaphor a lot about what do they say about, oh, sausage. When you make sausage, it looks kind of gross. When you have it for breakfast in the morning next to your pancake, it tastes pretty good. Now, I say this as somebody that used to eat sausage, but now I'm a vegetarian. But man, I still love the way it smells and I remember how good it tasted. But the point is that when we leave that room of having a difference of opinion, instead, when we leave the room and we're talking to non physicians about the direction we think healthcare should go, that's where unity is critical because I think those like the challenges we face, whether that's insurance coverage, whether that's funding of NIH research, when the million physicians in this country seem like we can't even agree with each other, it's a pretty darn easy job for those people that do what we don't want them to do to say, hey, we don't have to change squat. Look at them fight amongst themselves. That's a pain. And so that's why I think that having unity in our overall goals, right? At the specialist level, there's going to be things that I need, things that you need. Those are different things. Sometimes even tension in between related to we want to do these things and you guys want to do them. And that internal conflict, that's not even what I'm talking about. I'm talking about things like research funding. We all see the need for that. So when we leave those rooms and have unity in what we say, we're much more likely to be successful. And so that's all I ask is let's be unified as physicians when we want to improve healthcare in certain ways.
I couldn't agree more. And I think as physicians, it's really easy to forget those commonalities that drive the mission behind most of what we do, which is caring for our patients. And maybe it's easy to remember our differences as people and our different ideas and opinions. But at the end of the day, we're all bound by the same original oaths and Hippocratic oaths and our really kind of duty to guide and inform medical practice as a team together.
I remember seeing research in something I studied about in the C-suite of a for-profit company. If they take just a couple geniuses and assume that that's going to get them where they need to be, it turns out research says that's not right. When you put diversity in that room and you have multiple different aspects on life in general, you end up with a better product. And I think that's exactly what you're describing.
Absolutely. And the need to just focus on our shared goals and shared missions and focus less on our differences. The AMA is, of course, heavily involved in advocating for federal funding, including for cancer research, but money isn't the only thing that the AMA advocates for. The AMA, for example, has long been involved with things like prior authorization reform to reduce administrative burdens on physicians and patients. And in cancer research, one issue we've seen in the United States has been an ever increasing bureaucratic burden to open and run a clinical trial. As we talk about trying to move the needle forward for our patients, it's not uncommon for it to take a year or more, or even longer, to open a clinical trial in the United States, which is often longer than it takes in other countries. And for this reason, many of our industry partners for clinical trials increasingly turn to other countries to conduct clinical trials, which means that patients in those countries may have earlier access and opportunity to get cutting edge care. Do you see anything the AMA could do to help rein in the bureaucracy and cost of doing clinical trials in the United States to reverse some of that trend?
For sure. As I mentioned before, the Health 2047 work we're doing to sort of make it easier to do clinical trials. I know if I did one in my office, it's going to be a heck of a lot cheaper than doing it at the university an hour away. So, yes, there is something wonderful that can happen for the speed of development of our science when we involve practices like I have and the other ones like me that can do that. What's again very interesting to me is Dr. McCary had almost the exact same thing to say. The head of the Food and Drug Administration was talking about the efficiency and speed that we want to evolve the way that we take care of patients is something that he makes a priority. And so I found myself nodding big time when I heard him say this, because that's exactly, I think, what your question is about, is to move this faster, because that's what's exciting, right? That's what's going to improve our ability to live longer, higher quality lives. So yes, the AMA is very involved in that. And this was a presentation that he made to a room full of doctors. And it's that interaction when we share what our goals are, when they align with what the goals of the people that can make this happen, that is a wonderful moment.
Well, Dr. Mukkamala, I know you're an incredibly busy guy, and I just wanted to thank you again for joining us on the NRG Oncology podcast today.
Oh, thank you. And I never consider myself too busy to have this conversation. In fact, every day that I wake up, I Google how many days left in my presidency. And not because I don't like it, but when you see the finish line at the end of a race, you run harder and you run faster. And I think just this conversation is all of us kind of running harder. So thank you.
Today, we heard from Dr. Bobby Mukkamala, the 2025-2026 president of the American Medical Association, speaking about his career, cancer advocacy, and his own cancer journey. In keeping with our focus on the patient experience and health policy that matters to them, our next guest on the podcast is Dr. James Yu, who has spent his career working on patient-reported outcomes and their implications for health policy.
Dr. James Yu is a professor in the Department of Radiation Oncology at the Dartmouth Cancer Center in New Hampshire. Dr. Yu is a prolific cancer researcher with hundreds of publications, is currently the editor-in-chief of JNCI Spectrum, and is a member of the NRG Oncology Genitourinary Core Committee. Today, Dr. Yu joins us for a conversation about prostate cancer, which is the most common cancer affecting men in the United States. Dr. Yu, to start off, can you tell us about your involvement with NRG Oncology and the NRG Oncology program at Dartmouth?
First of all, thanks, Dr. Henke, for having me on this award-winning podcast. I'll talk about Dartmouth and then how I got involved at NRG. Dartmouth is a rural NCI comprehensive cancer center. Most NCI comprehensive cancer centers are in urban areas, but Dartmouth services a relatively rural population. It's also relatively small in terms of medical school size and academic department size. but it is a lead academic site for NRG. And I looked back at our accruals. We had 32 accrual credits from July 1st to December 31st of last year. So that is not a bad sign at all. So Dartmouth does punch above its weight. Our PI at NRG is Nirav Kapadia, who's terrific and has been instrumental at selecting high accruing studies. And so we're very committed and involved with NRG. I started involvement with NRG around 15 years ago when I was just coming to meetings as a junior attending. And I remember sitting in the audience at NRG Radiation Oncology Committee meetings just in awe of all these big names coming up and talking about their studies and development and just how cool it was to hear about research that hadn't been published yet. And so anyone listening who hasn't been to an NRG meeting, that is one of the really neat things that you get out of going to the meetings. Fast forward to about 10 years ago, I was running around Astro trying to get data for a study idea I had with Skylar Johnson, who's now at Utah, to compare moderate hypofractionation and SBRT for prostate cancer in terms of patient-reported outcomes. The reason for this was we were trying to get funding for a registry type study from NCI, and we got 5th percentile on an R01 that was not funded because they heard there was this randomized study coming out of NRG. We didn't get funding, so we were trying to get a comparative data to move on to the next step. And we wrote this study comparing patients who had been enrolled on prospective studies in a meta-analysis. And then I heard kind of out of the blue from folks at NRG. At the time, it was Felix Feng, who's been absolutely instrumental in my career, and Rod Ellis, who was the PI of GU005 at the time. And they needed quality of life data. They needed some sort of data to hang their hat on to power the study because NCI had asked them to make quality of life as a co-primary endpoint. And so we were the only ones who had written a study like this. And so that got me in the door of this study. I think the lesson here is that one way to get involved in NRG is to just do research that you're interested in. And if it's contemporary and helpful for study PIs, they will reach out to you. But the other lesson is that NRGGU is a group of people that is willing to reach out to new investigators. Felix set the tone of being a super welcoming group, and that's kind of gone forward with new leadership in Paul Nguyen and Jason Estathiou.
You are known as a researcher who hasn't focused on what some traditionally would call the harder outcomes in oncology. Rather, they call these softer outcomes that aren't related to things like survival or tumor control. Can you talk about the importance of these outcomes, for example, patient-reported outcomes, and why they are important to measure in prostate cancer trials like convenience, quality of life, financial considerations? Why are these outcomes arguably just as important as the harder outcomes like tumor control or survival?
For prostate cancer, it takes many, many years to show an overall survival difference or even a metastatic disease-free survival difference. Patients don't die as quickly from prostate cancer, and the difference in treatments really is quality of life. That's why patient-reported outcomes have become so important for prostate cancer. The other thing is, as we shorten our treatments, like what's the real difference between like 5 treatments and 44 treatments? It may not be in terms of how long you live, but it may be whether you keep your job or not, or whether, you have difficulty taking care of your kids, or whether you spend a lot of money on transport costs or stress during that time. These softer endpoints are still very, very important for patients. And those are the endpoints that are difficult to measure outside of these larger cooperative group studies.
When you go about designing these clinical trials with NRG that assess patient-reported outcomes, they are often abbreviated as PROs. What are your major considerations? For instance, how do you assess whether a particular PRO is validated and how to statistically power that endpoint? With the increasing scrutiny over trial finances and complexity at all levels, what kind of budget considerations are there for including patient-reported outcome surveys or other measurements in these studies?
I'm going to keep it real here. The way to know that it's been validated is whether it's been used before in a large study and whether there's a whole bunch of papers that have been written about how the survey was created and then the test, retest validity, all this stuff. There should be a body of literature around the survey that you're about to use. And if you're going to use it in an NCTN study, it should have been used in a prospective study as well. No one should be writing a survey for the purpose of using it in an NCTN trial. It's just not going to happen. There's a whole body of literature on how to create these surveys. You have to have a focus group, you have to pilot test it, you have to do a principal component analysis to make sure you're not duplicating or questions. You have to make sure it's reliable and consistent. So do not just create a survey thinking that you're going to use it in the NCTN. You're never going to get it past committee. The budgeting side of things, we don't usually budget explicitly for patient-reported outcomes in the sense that it's like, X number of dollars per question. What happens is the more surveys you have, the more question burden you have, the more scrutiny it's just going to get at the NCI level. I'll give a practical example for NRG GU13, which is the High Five study. The principal investigator is Karen Hoffman. The co-chair for PROs is Grace Smith and myself. When we started thinking about patient-reported outcomes for that study, we wanted to include patient-reported outcomes that were done in other studies for prostate cancer, like that's EPIC, which is the Expanded Prostate Index Composite. The EQ5D, 5L was included. And then we're wondering, okay, what else may be different between 5 and 28 treatments? Maybe fatigue, maybe work productivity, maybe cost of care. And so we put forward 3 additional survey instruments. We did have some data for fatigue, and also we really pushed for at least including the cost one. That's 46 questions total if you look across all of the survey instruments, which is pushing it. And I would tell investigators interested in PROs to really try and ratchet down the number of questions. Know that the more questions you propose, the less likely that's going to be accepted. You're going to have to go to longer distance between endpoints. Maybe only do the questions once a year rather than every 2 months or every 3 months, because it's just not feasible for the study staff.
I think that's a really great thing to point out. Patient-reported outcomes are critically important. I think some of the younger investigators out there maybe don't recall the times in which those weren't included, but treating GI like I do, there's years of reporting on acute toxicity outcomes, but far fewer years on reporting patients' perception of what those toxicity mean. And that is equally, if not more important, and probably a lot more granular. But if you give people survey fatigue, anybody, not just patients, the quality of the data that you start to pull in is going to go down and down and down as people get sick of replying and responding to those survey questions. As one of the leaders in the field of patient reported outcomes research, apart from these really practical considerations, how can investigators get involved with this kind of work? Practically speaking, how hard has it been to get your feet wet in the patient reported outcome space at NRG Oncology?
Everybody I've met through NRG has been very welcoming and interested in this type of work. And honestly, sometimes it's hard to find enough people who are interested in patient-reported outcomes. If you're truly interested, study the disease that you're interested in and just start asking questions about patient-reported outcomes in a prospective data collection at your own institution. Ideally, you get a grant so someone else keeps track of like the mailing out of surveys, et cetera, but you can do it yourself. I think the busier you get, though, the more you'll realize that you're forgetting to send out surveys or there's a ton of missing data. So ideally, get a grant if you can. If not, find a willing resident or medical student and do some prospective data collection. And then once you have that data and you publish on it, I think people will notice. And when they're writing a study that they need patient-reported outcomes for, which is most NCTN studies, they'll reach out to you or somebody will alert them to your work and you can be involved that way. I would say if you're at a meeting and you see a study concept being presented, like at the earliest stages, like at the disease committee level, you can reach out to the study PI. If you're at an institution with an NRG study open, enroll patients on the studies so you can see how intensive the patient-reported outcome collection can be. Just get involved, do some research on your own on patient-reported outcomes. And if anybody has any questions or wants to talk over strategies with me, I'm happy to talk with anybody who's listening to this podcast.
There's one final question that I'd like to ask you about. I'm sure that you, as well as most of us listening, have heard about the changes potentially in federal policy pertaining to NIH and NCI funding that could affect groups like NRG Oncology. How worried are you about the potential funding cuts and the impact they could have on things like patient-reported outcomes and some of these assessments that you do in these clinical trials? And what, if anything, can we potentially do to mitigate some of these costs?
Well, I think patient reported outcomes, as far as I know, is not immediately under threat. So I heard through various committee and societies that NCI itself does not seem to have a ton of funding cuts that are planned, but you never know. I haven't heard about patient reported outcomes being cut from NCI trials. Hopefully, I'll be right and patient reported outcomes won't be impacted.
Well, Dr. Yu, I just wanted to thank you again for joining us today. I want to really commend you on laying out the field of patient reported outcomes in cancer and making it seem so easy and seamless to get involved with NRG oncology.
Well, thanks, Steve, and thanks, Lauren. Yeah, I just want to end with talking about the one person that got me involved with NRG in the first place, who was Felix Feng. And his passing was a huge loss to our field. And, not a day goes by where his impact is not felt. And I know I got into patient reported outcomes and NRG through Felix and his just kind of waving me in. So just want to end with that.
Today, we had Dr. James Yu, professor of radiation oncology at Dartmouth. He is a member of the NRG Oncology Genitourinary Core Committee, and he was speaking to us about patient reported outcomes for prostate cancer. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect that of the National Institutes of Health. Thanks for listening in, and happy clinical trials.